prevention and treatment. And kidney disease might be somebody within your family who's suffering from that. It might be somebody who is outside your family, but it's very important to know about some of this. So I hope you will all enjoy this talk and learn something, and hopefully we will be better in terms of managing and treating this kidney disease. So basically, first is you must understand the kidney human anatomy. So kidneys are bean-shaped organs which are on either side of our abdomen. So we have one on the right side, we have one on the left side, and they are connected. Ureter is a pipe that actually takes the urine to the bladder, and from the bladder, it comes out through the urethra. So if you look at the kidney itself, they're very small size, and a lot of people don't know that the kidneys are very important organs. As kidney specialists, we say it is one of the smartest organs in the body. So why do we say it is one of the smartest organs? We all know that the heart pumps blood, and that's all it does. But the kidney does a lot more. So one of the main function of the kidney is to ensure water balance. So it makes sure that whatever you're drinking and you're removing, because if you don't drink, if you drink too much and you don't remove enough, what will happen is that your body is going to retain all these fluids, and you'll start swelling, and eventually the water will go into your lungs and you'll come in having difficulty in breathing. So kidney helps in water balance. It only retains what it needs, and if it doesn't need it, it removes it through the urine. The second thing that it does is it helps in blood pressure control. Most people don't know that kidneys are very important in blood pressure control. In fact, sometimes kidney damage is what starts as blood pressure, high blood pressure. And people say, oh, I have high blood pressure, but they've not yet checked their kidneys. And what happens later on is that you find that it was the kidney that was suffering that caused the high blood pressure, but it was not treated on time, and people then end up in kidney failure. So any new onset of blood pressure, you must check your kidney function, because there's something going on, and we have to make sure it's not the kidney that is suffering that is causing the blood pressure. At the same time, there are people who get essential primary hypertension, which is not related with the kidney, but if not well controlled, can eventually lead to kidney damage. So blood pressure is a very important thing for the kidneys also. Now, the third thing it does is it eliminates waste product. Urine is not just water. Urine is also waste products, and that is how it comes out from your body. Now, the minute the kidneys don't remove the waste product, what happens is that you get accumulation of the waste products in your body. You find that you don't have energy, you are lethargic. Sometimes you can become confused because of the high toxin buildup, and sometimes you might get just acidity-like symptoms. Kidneys are very important for your bones. Most people don't know that. So kidney, what it does is that we all get vitamin D from the sunlight, but vitamin D from the sunlight is in an inactivated form. So the kidney has to activate the vitamin D for the vitamin D then to be used in calcium absorption in the body, especially for your bones. Now, what happens in kidney disease is when the vitamin D is not activated, your body feels that there's no calcium in the body, and you lead to weakening of the bones, because that's where the calcium is removed from. The next thing that it helps in is acid-base balance. In acid-base balance, you know that all our cells and enzymes work at a certain pH. pH means that they work at a certain acidity, alkalinity level. Now, for all our enzymes and hormones and everything to work, if our body is too acidic or too alkaline, some of these things will not work. And the kidney is what actually controls all this. It controls the environment so that your body and your enzymes and your hormones can work well. The kidney is also very essential in terms of salt balance. And some of the salts that are important are sodium, potassium, and calcium. Now, what happens is when your kidneys don't work, then you can get derangements in the levels of this salt. Like you can get very high potassium levels, and very high potassium levels will eventually cause arrhythmia to your heart. By arrhythmia, it means that what your normal heart is supposed to be beating at, your heart starts beating either too fast or too slow, and this eventually leads to cardiac death. So electrolytes are very important, and they're regulated by the kidney, and they ensure that the heart works well. And another thing that most people don't know is that the kidney also helps in building blood. And building blood, it doesn't make blood in the kidney, but it makes a substance called erythropoietin. Now, erythropoietin is like a signal for the bone marrow. When erythropoietin is produced, it tells the bone marrow, make blood. And when erythropoietin is not produced, the bone marrow does not make blood. And because of that, you find kidney patients usually have low blood levels. So that is why we always say that kidney has various functions. They're very small organs, but they do a lot more. So we look at kidney disease and prevalence, and we find that there's very high prevalence of kidney disease in the world. 850 million people suffering from kidney disease is such a huge number. Compare it with people who are having diabetes, 422. So we are double the people who have diabetes, and it's 20 times more than people suffering from cancer, 42 million, or people suffering from HIV/AIDS, which is 36.7 million. Yet, if you look at it, most people don't talk about kidney disease, but people talk about diabetes awareness, they talk about cancer awareness, they talk about AIDS and HIV awareness, but very few people talk about the kidney, yet the numbers are quite huge. And not only are they huge, but the numbers are rising. So if you look at the people who are end-stage renal disease, that is at the last stage of kidney disease, and people who are starting dialysis, you look at 1990, we had around 500,000 people. This number doubled in the next 10 years and again doubled in the next 10 years. So if you look from 1990 to 2010, the number was 4 times as much. And this is very concerning to us because if we don't stop it, then we'll have higher and higher numbers and it is not sustainable. Now, why are we talking about this kidney disease? I mean, why should it be very important? Because kidney diseases are linked with cardiovascular risk. So these are people who have high prevalence of heart attacks and high prevalence of stroke. Now, if you look at the chronic kidney disease prevalence and you look at these countries, these 12 regions that were taken, and you see they're quite represented. We had some Indian countries involved, we had some Arab countries involved, we had some African countries involved. So we can say that this is basically an overview of what population we have in Mombasa. And if you look at the kidney disease prevalence in the general population, it was 14.3%, but it was much higher in a higher risk population. And we look at high risk population, we say the diabetics, the hypertensive, and you look at it was 36.1% kidney disease prevalence. So that's quite a huge number. And if you look at kidney disease leading to years of life lost, and if you look at leading causes, in 1990, kidney disease was at number 25. By 2005, kidney disease was now the 21 cause of years of life lost. And by 2015, it was at number 17. If this is the trend we are going to go on, we'll soon find that kidney disease is one of the main leading causes, maybe even top 10 leading causes of years of life lost. By years of life lost, it means people who die early, who are probably handicapped because of this. Now, we look at risk factors for kidney disease. We talked recently about, we just said that in the high risk population, the prevalence of kidney disease was 36.1%. So who are the high risk population? The diabetic. And I'm finding, I used to work in Nairobi Hospital before, And I've come to Mombasa and I'm finding a lot of kidney disease caused by diabetes in the Mombasa population. And that is probably because of the type of diet we have, the type of lifestyle we have, that we get diabetes early than other parts of the country. The second thing is high blood pressure. We have a lot of patients with hypertension who are poorly controlled. A lot of people tend to think that diabetes, hypertension, it's a crime to be on medication. And they'd rather be not on medication, but suffer without it. What they don't understand is that eventually it leads to kidney damage. The second thing, the other risk factor are people with heart problems. You find that if you have a heart problem, you will eventually get some kidney damage also. Obesity. Obesity is a risk factor for a lot of diseases. Sorry. Obesity is a risk factor for many diseases, including diabetes, hypertension. So you find that this is also a risk factor for chronic kidney disease. There are some people who have a genetic predisposition to kidney diseases. And so, I'm sorry, I'm fasting, and right now when I talk too much, my throat gets dry. So there are a lot of people who get a family history of kidney diseases. So if you have a family history of kidney disease, at least try and check your kidneys once in a while. Smoking is very bad because smoking causes a lot of stiff arteries and veins, and eventually impedes your blood flow to the kidney, to the heart, and causes a lot of organ damage. Now, age, 60 years and older is also a risk factor, because remember, you are having these organs that are also aging with you. So the function of the kidney reduces with age, and these are patients who are very susceptible to any damage. So as you grow older, you shouldn't really be taking, you should be taking more care of your kidneys, because anything can push it to kidney failure. Now, you must understand that there are two types of kidney failure. There's the acute failure and there's the chronic failure. A lot of people come to me and ask me, will my kidney recover? That's because you don't understand the acute and chronic. Now, acute is when you have a very good kidney and you develop some injury. And it could be because of trauma, maybe some accident, surgical, or some acute drug overdose, or maybe you are sick with infection and now your multi-organs are failing, or other infections such as that you lose a lot of water in your body, and because of that your kidney gets a bit injured. Now, acute injury usually has a chance to recover because you started from very good kidneys that were managing very well, so they have a chance to recover. There are some people who don't recover from acute injury, and those are those who are at a higher risk factor. Because, for example, let's just see a 60-year-old male who's diabetic, hypertensive, then gets an acute infection. His kidney might not recover because he already has very many risk factors for kidney failure. And what happens is that their renal reserve, that means the ability of their kidneys to recover, is very small. So when they get an acute injury, some of them go into chronic damage. Now, chronic damage usually occurs over years, months and years, and they are irreversible. So by the time you're coming a diabetic, hypertensive, I'm seeing your kidney working at 15%, those are not kidneys that will recover. There's nothing that will make them change, even if you go to India. There's this concept that if you go to India, everything will be changed and they will revive your kidney. There's no country in this world that can revive your kidney if it is chronic damage. the only thing we can do is stop the damage from continuing. So we make sure that if you have 20% of your kidney working, let us have it working for the longest time ever before you need dialysis. And most of the chronic causes are high blood pressure, diabetes, some chronic bacterial inflammation, some chronic inflammation of the kidneys, some such as chronic glomerulonephritis, some genetic diseases of the kidneys, such as polycystic kidney diseases, and some autoimmune diseases such as lupus nephritis, protein in the urine, blood in the urine is very important. Don't stay with protein in the urine and blood in the urine and take it that it's normal. It's not normal to have protein and blood in the urine. So a lot of people are managed out there, and you can't really blame, because sometimes not everyone is a kidney specialist, and sometimes, I mean, if everyone was a kidney specialist, I wouldn't be here talking to you. So sometimes it is treated at the right time, and by the time you come to a kidney specialist, those kidneys are gone. Now, why are we always talking about kidney disease? I mean, why is it bad to have kidney disease? Because the outcomes are severe. You are at high risk of cardiovascular death. You are at high disease. Plus, it also leads to a diminished and disability. So you find your quality of life is diminished. You are disabled somehow, not physically disabled, but you are not as strong as you used to be. You're always weak. So your quality of life is not the best. Plus, it also leads to death. Now, we talk about chronic kidney disease and stages of chronic kidney disease. So we have stage 1 to stage 5. And as you go up the stages, the higher the stage, the worse the kidney is working. So stage 1 is whereby your kidneys are still working well. So if you were to do a blood test, and if a doctor was to read out to you, they would say, oh, your blood tests are very well, your kidney is working very well. And really, it would be working very well. This GFR means the glomerular rate, and we use your age, we use your creatinine level to calculate your glomerular filtration rate. 90 or greater is very normal. So 90 or greater is very normal. However, if you were to check your urine, maybe you have some slight trace of protein or slight trace of blood in it. And the doctor will tell you, no, it's all right. I mean, your kidney function is quite well. This is just, don't worry about it, it will clear. So you go on, you say, oh, it's going to be cleared. The next time you go, now your creatinine level has decreased. It's probably around 60 and 89. And there's still mild kidney damage. You know, you feel very well. I mean, you still don't have symptoms in stage 1. You don't have symptoms in stage 2. Then the doctor might tell you, no, it's still very good. I mean, 60 and above is quite good. There's nothing to worry about. In fact, if you look at most of this GFR calculation, they tell you above 60. They don't tell you it's 70. They don't tell you 75. They tell you it's above 60. So you are feeling well. You go on. You continue with your normal lifestyle. Next thing you know, you're stage 3. Or probably you jump from stage 2 to stage 4 because you have taken so much time. You've been well. There's nothing going on. And suddenly now you're unwell. So basically, before your kidney starts showing damage, you'll probably have reached stage 4 or stage 5. And stage 4 is when your kidney is working at 15. This GFR, you can take it as a percentage. So it's either working at less than 30% and almost less than 15%. This is where the symptoms start. And by that time, it's too late to save. maybe here we could have done something about it. And if we had not done something to save it, we could at least have stopped it going very fast down to stage 5. So that is why it's very important to check your kidney function test. And like I said, before the symptoms really come, uh, initially there are no symptoms. You will feel very well, but your kidney is slightly decreasing. By the time you face symptoms, you can have various symptoms. You can have reduced urine output. You can have fatigue, nausea. You have swelling in the feet, because I explained to you that the kidney is very important in water balance. And when the water is not coming out, then you start getting feet swelling. You get tiredness, fatigue, and that's because of the toxins that are not coming out. Poor sleep, poor appetite because again the toxin buildup causes a bit like acidity-like symptoms. You get unexplained itchiness, and this is again the toxin buildup in the skin. You get puffiness around the face and eyes, and eventually, because swelling in the feet, there's a certain amount that water can go in the feet, so it has to find another place to start accumulating. It starts accumulating in the lung, and you get short of breath. Now, prevention is always better than cure. And how do we prevent? One, we should look at the high-risk patients. We've already talked about high risk, but I just cannot insist what the high. It's very important to keep insisting what the high risk: the diabetes, the hypertensive, the ones who have cardiac diseases, the elderly above 60 years. If you have a family history of kidney disease, um, if you are so ethnic and racial properties, we can't really say that we are one of those ethnic and racial properties. However, Indians do have a higher risk of kidney injury. If you have a history of an acute kidney injury, maybe you were once admitted to the hospital, you had cholera, your kidneys a bit took some damage, but they recovered. Always remember that once the kidney was hit, the kidney slightly remembers that it had some damage. It doesn't disappear altogether, even though your kidney function test will be all right. So it's always good to screen your kidneys and to check for your for your kidney function test at least yearly, or at least once in 6 months if you can afford. Other than that, how do you screen? So you do a urine test, and in the urine test, you're looking for proteins. Most of the time, the proteins are albumin, and you also look for blood in the urine. So this urine has to be done on a day that women are not menstruating, okay? And the second thing that you need to do is your blood test for kidney function test, that is creatinine, urea, and potassium levels. And if anyone has a decreased GFR, less than 30, they should be sent to the kidney specialist. But actually, this is in countries where they have better health systems, where even they have access to physicians, they have access to everything. So that is why where the kidney specialists are overwhelmed, so that is why they only say refer less than 30. But in our system, where healthcare access is not the best, I think you should come if you have a reduced glomerular filtration rate, and you shouldn't wait for it to be at less than 30. And if anyone who has protein in the urine or chronic kidney disease of unknown etiology, that means they're not diabetic, they're not hypertensive, they are not cardiac disease, and suddenly they have kidney disease, those are patients who need to be seen very urgently to find out what is going on. If they have a very fast drop in the glomerular filtration rate, if they have kidney complications, persistent high potassium levels, remember I said high potassium levels can cause cardiac arrest. So it's very important for potassium to be controlled. If you have blood in the urine, which is unexplained, if you have blood pressure, which is very difficult to control, if you have history of recurrent kidney stones, or you have any hereditary kidney diseases, then you need to come in early. Now, recently we had a screening camp in Mombasa, in Kilifi and Voi, and it was done in the month of March. Usually the World Kidney Day is celebrated every year, and every year, not only Kenya Renal Association, but also private hospital carry out this World Kidney Day screening camps. And during the screening camps, we usually do a free urine urine check and a free blood pressure check, free blood sugar check. And the reason for this is we are trying to see if you are one of those at high risk of kidney injury. Do you have diabetes? Do you have a hypertension? Is it well controlled? How is your urine? And at that point, if there's any problem, usually at this camp, they were able to see me at the camp free of, it was a free consultation. So unfortunately, this year has passed, but it's for you to know that if you ever find such a message coming from the hospital that there's a World Kidney Day free screening camp, then I would advise you to come and come and make use of this opportunity. Usually you don't pay anything. And it's not just Aga Khan that does it, but even the national government does it. It's also there in the Coast General. So maybe Aga Khan is too far for you. So even go to Coast General. It's better to know if you have kidney disease than not knowing and it's too late. Now we come to and we talk about how to have a healthy kidney. So one, be fit and active. By being fit and active, you're making sure you're not having diabetes, you're not having hypertension, and eventually you're not having kidney disease. Eat a balanced diet and avoid this refined foods. By refined foods are such as crisps, chips, oil which is refined a lot. So avoid such things. You drink adequate water. And one of the challenges I see in people, and when I meet them and I ask them, how much water do you drink? I drink a lot of water. And when you ask them what is a lot of water, they'll tell you, oh, I drink like two glasses of water. That's not a lot of water. So adequate water means 2 to 3 liters in a day. So that is enough water. But at the same time, I don't want you to go overboard. I don't want you to go more than 3 liters. There are people who decide that, oh, to avoid kidney, let me drink 5, 6 liters. That is not what I want. Remember, we said the kidney has to try and regulate the water balance. So it has to remove all the excess water. So if it has to remove all the excess water, you'll be losing a lot of electrolytes again. Remember, it was also balancing your salts, such as sodium, potassium. So when you drink a lot of water, you get low potassium levels and you get low sodium levels. So 2 to 3 liters should be okay. If you are smoking, you should quit smoking as of now. If you're diabetic, you must make sure your sugar is well controlled, because diabetics generally, so people generally lose a part of their percentage of the kidney function every year. But in diabetes who are poorly controlled, that loss of kidney function is greater and is very accelerated. So you want to stop that. You want to make sure that the loss in kidney function is almost as normal as a person who is non-diabetic. Make sure your blood pressure is controlled well, because if your blood pressure is not going to be controlled well, the kidney will get damaged, and a damaged kidney is going to cause more hypertension, and it will be very difficult to control the blood pressure. Now, one of the problems we face in Kenya is that we have a lot of over-the-counter prescription. People tend to trust the pharmacist much more than their doctors. So whenever they're unwell, rather than going to see a doctor, they go to the pharmacist and ask for medication. And a lot of time there's overuse of antibiotics, there's overuse of painkillers. So NSAIDs are non-steroidal anti-inflammatory drugs. Now, some of the NSAIDs that are available are diclofenac, Voltaren, Brufen, Zolo. And a lot of people, when they're in pain, they tend to use those medication because, I mean, they're stronger than Panadol, so and people feel better. So you find a lot of people using diclofenac, Voltaren, Brufen, a lot of it. And this medicine can cause kidney damage in the long-term use. So avoid non-steroidal anti-inflammatory drugs. Panadol is usually safe for pain, but otherwise diclofenac, brufen in a chronic use will cause kidney damage. It will also cause hyperacidity. Not only that, even some over-the-counter prescription for antibiotics can cause kidney damage. So don't just go and get over-the-counter prescription without knowing what is causing and the problems. Sometimes you actually don't even need the antibiotic. Then herbal medication. We are in a society, I mean, I'm Indian myself, so I'm in a society where herbal medication is always appreciated, even in our, in our life where we grew up with herbal medication. But the problem with herbal medication is you don't know the side effect. So you don't know the side effect. No one has studied this herbal medication. No one has seen what damage it can do. And there's this notion that herbal medication are always safe. And that is not true. A lot of herbal medication can cause kidney failure. And plus, on top of that, when you go to these herbal doctors, they sometimes need to make you feel better. So they actually mix in this concoction some medicines which are actually pharmaceutical drugs, such as painkillers. And this has been done in a research. So in Africa, we are actually one of those people who have kidney injury because of herbal medication use. So be very careful. Not all herbal is safe, because if you go and you get, like, especially in Mombasa, you go someplace and you get this gololi medication, like, oh, this is herbal. How do you know what they put in there apart from the leaves and what else they added there? You don't know. And no one can tell you. Even the person will not write you all the things that are in there, because he knows that it can, some of them are not just herbal. And if you have a problem, or you have hypertension, diabetes, see a physician. And if you see proteins or you see blood in your urine, see a kidney specialist. Or if you see that your kidney function test is declining, see a kidney specialist early. Now, nutrition. So it's hard to talk about nutrition in kidney disease, because let me give you an example. When you are diabetic and you go to a nutritionist, the nutritionist will tell you, avoid whites, take brown. But now the same diabetic eventually develops kidney failure, and goes to the nutritionist, and the nutritionist tells you, don't take brown, take white. So you get confused. You say, but I was told to use white, and by white, white rice. And then when you were just diabetic, you were told, change from white to brown rice, brown bread, brown flour. And now you have kidney disease, and the nutrition, and you still have the diabetes, but the nutrition is telling you, no, now you can't eat brown, you have to go to white. And you're wondering, but my diabetes, what about my diabetes? Because diabetes, for patients, diabetes is always more important than the kidney. And you wonder why the nutritionist is doing like that, and you say, oh, this nutritionist doesn't know what he's saying. But that is it. One size does not fit all. There's not one diet that is applicable to all kidney patients. However, we usually say, the things we say is low sodium, low potassium, and low phosphorus diet if you are in chronic kidney disease, and see a nutritionist. A lot of people don't go and see a nutritionist. Most people think that they know what they can eat. Most people are able to Google what they can eat. And most people think that the doctor should be able to tell them a proper nutrition plan. However, if that was the case, then we wouldn't have a nutritionist. And nutritionists are very important because they give you a proper meal plan depending on what you have: diabetes, hypertension, kidney disease, any other condition. So it's always important to see a nutritionist who can tailor your meal plans according to your needs. Now we talk about treatment. Now again, treatment is not the same for all the patients. A diabetic will not get the same treatment. Those who have inflammatory diseases of the kidney will not get the same treatment. So one treatment is not for everyone, and it will be depending on the patient characteristics. And when we say the treatment, we are hoping that we are going to ensure that we are delaying as much as possible the point where you need dialysis. The whole point is to delay the onset of dialysis. And onset of dialysis is usually at stage 5. And stage 5 is when you are at end stage kidney failure. It is the last stage of the kidney disease. And your kidney is working at less than 15%. And that is when all the symptoms come in. Now, a lot of people have fear of dialysis. Dialysis is not something to be feared about. It will actually improve your symptoms. It will help you feel a bit better. Now, what is dialysis? Dialysis is a procedure whereby blood is drawn from your body, passes through this machine, and the machine now acts like an artificial kidney, takes out the excess fluid, takes out all the toxins, and once the toxins and fluid is removed, it returns the blood to the body again. Now, generally, dialysis is not a painful procedure. You actually don't feel any pain while undergoing dialysis. However, there's usually an access that is needed, and those are catheters. You can have a catheter or a fistula. And during that procedure, you might feel a bit of pain, but we give you local anesthesia as we put the catheter or we do the fistula. But after that, you shouldn't feel any pain during dialysis. Dialysis usually lasts around 4 hours, and you do it twice a week because NHIF pays for it twice a week. In some of our patients, we sometimes ask for a third session. Depending on the circumstances, sometimes they have to pay for the third session, or sometimes we use the spouses NHIF to get a third session accepted by the NHIF. Now, remember the kidneys you are having, and while you're sitting here and listening to me, remember you have 2 kidneys and they're working and they're still producing urine, and you probably, some of you feel like you need to go to the washroom, this doctor is talking too much. Remember, your kidney is working, never sleeps. It works 24 hours a day, 7 days a week. It has no leave, it has no rest, it has no vacation. Now imagine this dialysis that you are going twice a week for 4 hours, that's 8 hours. And compared to what your kidney was working, it's not going to be the same. So dialysis will never be the same as your original kidneys. And that is why it's very important to save your original kidneys and not reach dialysis. So you will never ever feel as strong as when you are not on dialysis. You will always feel a bit weaker because the kidney treatment is not, the dialysis is not every day and it's not 24 hours. Now at Aga Khan Hospital, Mombasa, and we have just updated our dialysis unit, and we have actually the latest technology of dialysis, in fact, in Kenya and in the world. We have something that we can offer online, hemodiafiltration. These machines are better. They're much more tolerable to the patients. They have less interruptions during dialysis. The patient also have told us that they are feeling much better with these machines. Now, sometimes people say dialysis is dialysis, whether it's done here or there, and that's not true. A lot of things are put into dialysis. One is the staff competency. The second is look at the machines we use. The third thing we also look at is the quality of water used. A lot of hemodialysis centers don't really look at the toxin levels, and usually they have toxin in the water, and patients feel very unwell even after dialysis. So dialysis is not just dialysis. there are a lot of things we are doing when we are offering you the service. Um, and it's nice to be at a very good center when you're dialyzing. Now, remember I told you dialysis is not the optimal treatment because it's never going to replace your kidneys, the kidneys that are working 24/7. The only optimal treatment is kidney transplantation. So a lot of people have questions to me when they come in. They say, what is kidney transplant? Okay, so kidney transplant is taking a kidney from a donor who has voluntarily agreed to donate his kidney. It can't be a coerced thing. You can't tell the person, oh, I'm going to give you 10 million, give me one of your kidney. That is illegal in Kenya. It has to be somebody who voluntarily agrees to donate your kidney. And usually by the time we do the procedure, it has to be a kidney that is healthy and the individual is healthy. We usually don't take kidneys from unhealthy individuals or from people who we are afraid that they will require that kidney of theirs. Now, a lot of people ask me, can one live with one kidney? And yes, you can live with one kidney for the rest of your life. Even if you donate to a patient, there's no problem in that. You can live for a very long time with one kidney as long as you have a healthy lifestyle. The second thing that people keep asking me is now the patient will ask me, will they remove my kidneys, the ones which are sick? We don't remove those sick kidneys. We leave them there. So you, the person who is receiving the kidney, will have 3 kidneys in the body. The third kidney is usually done just above the hip joint. So it's put in the pelvic area. So it's just above that. Sometimes if you feel, you can even feel it there, if you touch your stomach. So we don't remove your other 2 kidneys. We just add 1 more kidney to you, and it's around the hip region. So kidney transplant, if you look at a study done in South Africa, where they looked at the average length of survival on dialysis, they found it to be 5 years. So from the start of dialysis, 5 years, and people then had issues with cardiovascular deaths, as they had increased rates of heart attack, stroke. Now, I'm not saying that 5 years is the timeline. There are people who stay 1 year, there are people who stay 15 years. But averagely in South Africa, it was 5 years, and South Africa is almost a depiction of Kenya also, because it's not Europe or somewhere else. Now, transplant allowed people to live longer. Not only does transplant allow people to live longer, it also allows you to lead a normal life. Remember, this transplanted kidney is going to work and 24 hours. It's going to work 24 hours, and it's going to allow you to work, even to resume your normal lifestyle. It's going to allow you to do everything that you used to do before. It's going to allow you to even start working whatever job you are doing. However, you must know that you will be on a lot of medication for the rest of your life. After kidney transplant, you are going to be initially on very many medication that will slowly be reduced until you reach a stable state. And then you'll have medication, but not as much as at the beginning. So people have this notion that kidney transplant, once kidney transplant is done, then they don't have to take medication. That is not true. You will still be taking medication, but you'll feel much fitter. You'll have more energy. You'll feel like your life is back to normal. Women and male also who want to have children can have children while after kidney transplant. While those on dialysis, usually they have problems getting pregnant. They have problems getting somebody pregnant. So fertility is always an issue in kidney patients, and that resumes once kidney transplant is done. So always remember that you will always have medication to take, but that should not be a problem as long as you can continue with your normal lives. Now, this is again talking about surviving on dialysis versus transplant. Uh, if you look at the type of donors, we have living donors and we have deceased donors. Unfortunately, in Kenya, we don't have deceased donor. So what is a deceased donor? Somebody had an accident, goes to the hospital, is brain dead. And the doctor tells you the patient is brain dead, is in a vegetative state, there's no way we can help him. Are you willing to give his organs to somebody who needs? That's called a deceased donor. Because they remove the organs, the patient is brain dead and eventually he dies, and that is called a deceased donor. In Kenya, we don't have deceased donor program. We have only living donor program, whereby one of your family members donates, and after donating, they are still alive. Now, if you look at survival rates, of course, remember a living donor is always better than a deceased donor. However, so they have better functioning of the kidney. So if you look at the 10-year survival rate was 52.1% in living donor, 44% in deceased donor, while in dialysis patients it was just 18.6%. So most people were likely to die within 5 years, and that is what people must know, that dialysis is not a treatment and transplant is the only treatment for kidney disease. I find Mombasa people reluctant in terms of transplantation. There's a lot of lack of knowledge in terms of kidney transplantation. There's a lot of mistrust. Um, people believe that Kenya, we can't do kidney transplant. And I'd like to say that Kenya has been doing kidney transplants for a very long time. Yes, Mombasa, as the coastal province, we don't have a kidney transplant program, but there's a very robust program in Nairobi. There's a very robust program in Eldoret, and we are able to connect you to these programs. We are hoping that Mombasa, as a county, we are going to be able to start a kidney transplant program soon, because it is very much needed. And a lot of people say that India is better. So a lot of people tend to always want to go to India. I can tell you, after having managed a lot of transplant patients, India is not much better. India is not much cheaper. There's nothing such as India being much better or much cheaper. On the contrary, sometimes when you have to go with family members, because you can't go alone with the donor, you end up spending much, much more. And sometimes when you go for cheaper options in India, you come back in a worse position, because you come back with acquired infections from India that you never had, such as hepatitis C and B. So India is not much cheaper, it is not much better. And having worked also in South Africa, where we were transplanting there, I find that Kenya does just as well, if not better. I actually feel that having a living donor program and our process is much better than even South Africa at times. Now, if you look at people who start dialysis, let's say we had 100 patients on dialysis and we had 100 patients on who transplanted. By year 10, you'll find that those on dialysis, you're left with only 10%. While those on transplant, you'll have 80% of those patients still alive. So it's very important to note that kidney transplantation allows you to live longer than dialysis. So most people come and tell me transplant is very expensive, because the cost of kidney transplant in Kenya currently ranges between 1.6 million to 2.5 million. It depends on how complicated your procedure is. Out of this 1.6 to 2.5 million, NHIF pays 0.5 million. So you have to remove 0.5 million because NHIF pays for that. The drugs in the first year, remember I told you in the first year, it's going to be much more expensive because you'll have a lot of drugs to use. You'll be using much, much more drugs. The The first year might be around 540,000. However, I must say also that there are programs like Kenyatta National Hospital has programs where you can get these drugs for cheaper than in a private facility, and it's very easy to enroll you in such programs. So it's not something that we cannot enroll you in. In the second to fourth year, it's 180,000. So a lot of people say not only transplant is expensive, but even the drugs having to buy 540,000, then 180,000 is so expensive, I cannot afford. But you forget that if you are using 180,000 per year for your kidney transplant drugs, remember it's allowing you to work a job that you are not able to do while on dialysis, and you are able to earn an income. And I'm sure you can make up for much more than this 180,000. So it allows you to earn an income, at the same time continue with your kidney transplantation. While you're on dialysis, not only are you on dialysis, but you are always, so a dialysis session is 9,000. The catheter and the fistula, you are always having problems with catheters and fistula. Your catheter doesn't work. Each time it doesn't work, you have to pay 35,000 to 70,000 for catheter replacement. The fistula, 70,000, 50 to 70,000, doesn't work. You get infections. You are always sick. You are always unwell. You're not able to do work. And if you look at the cost of dialysis per session, in 5 years' time, with all this, just if I look just at the cost of dialysis per session, in 5 years' time, the total cost comes to 4.3 million. And if I look at transplant, the total cost, including the kidney transplant, comes to 2.86 to 3.76. There's a vast difference in terms of cost. And not only is there a vast difference in terms of cost, what it will cost, but there's a vast difference because now you're able to go back and continue with a job, and you're able to earn income to support your family. So this 3.76 million will be nothing at the end of the day. Now, a lot of people come to me and tell me, yeah, but dialysis is paid by NHIF. I mean, if 9,000 is paid by NHIF, I'm not really going to spend that 4.3 million that you say so. But remember, you're always going to be sick. There'll always be some infections creeping up. Your blood level will go down. You'll get cardiac issues. You'll get heart failure issues. That's not a way of life that you want. You want to be able to live a normal, healthy lifestyle. So really consider kidney transplant. And because of that, because I find a lot of, since I've come to Mombasa, I find a lot of difficulty. I find most patients don't know a lot about kidney transplant availability, this information. At Aga Khan Hospital, Mombasa, we've started a kidney transplant clinic, which is every day, every Wednesday from 10 a.m. to 3 p.m., whereby we help you in pre-transplant counseling. In pre-transplant counseling, we help talk about kidney transplant, things that you are worried about. We help talk about transplant to your family members. Remember, it's not easy for any person to ask another person to donate a kidney. There's always going to be that reluctance from the family members because they're scared, they're worried, what will happen to me if I give out my kidney? And it's not a conversation you want to have alone. I always tell my patients, it's not a conversation you want to have alone, and it's not a conversation you should have alone. Let the doctor guide you in this conversation. Then if a family member willingly volunteers to donate, let it be that they're willingly volunteered to donate. But it's very much hard for you to start this conversation by yourself. Not only that, once somebody is willing to donate, we do the pre-transplant workup for the donor and recipient. Imagine if you had every time, if you had to go to Nairobi or Eldoret every time for your pre-transplant workup. Remember, I told you we look at this kidney donor and we make sure he's very healthy before we decide to take his kidney. And every time you have to go for the workup, you have to pay for the transport to Nairobi, an overnight stay, the doctor's fee, the test, and then come back. It's going to be very expensive for you, and those expenses are not catered in that in the figures I gave you before. So what we like to do is we like to work you up very well. I give you all the possibilities where you can transplant. And once we have all these possibilities and you have chosen where you want to go and transplant, whether it's Nairobi Hospital, Aga Khan Hospital, University Hospital, MP Shah Hospital, or in Eldoret, then we refer you to the nephrologist who's going to be there, and so that it can be done immediately and there's no delay. Because remember, the donor has to take also some time off from his workplace, and while he's doing all this, and we don't want to waste a lot of his leave days trying to get all this done. After transplant, we follow you up. Remember, you are going to go on some medication for some time, so we follow you up and we make sure the kidney is functioning well so that you don't end up with kidney failure again. So you're most welcome for our kidney transplant clinic. Now, kidney specialists are very rare. We are lucky in Kenya to have kidney specialists. There are countries in Africa that have no kidney specialist. But at the same time, we see that kidney specialists in Kenya are very few. We have less than 5 per million population rate. So if you are one of those few people who are able to get access to a kidney specialist, count yourself very lucky. Also, at least count yourself lucky that you have around 5 kidney specialists in Mombasa. I can say that for coastal province because all the kidney specialists are in Mombasa. So the whole coastal province, we are sharing 5 kidney specialists. Nairobi has much more kidney specialists. Eldoret has a few more. But other than that, Kisumu has 1 or 2, I think. But then other parts of the country are not having kidney specialists. So appreciate that you have kidney specialists in Mombasa, and if you can, come to a kidney specialist early. Now, a lot of people would say, why are the Khan Hospital Mombasa? What is it they offer better than that? So we have a full-time kidney specialist available where I'm usually here the whole time. Even if I'm not in office, I'm always reachable by phone. If you pass by the outpatient, they usually call me. We have daily clinics from Monday to Friday, 10 a.m. to 3 p.m. On Saturday, we have it on appointment basis, and we have a specialized transplant clinic that runs on Wednesday. So that's all from my side. Thank you very much. I hope you benefited from this session. I hope I did not talk too fast. I sometimes tend to talk too fast. So I hope you all caught up with my fast talking. Thank you.
Thank you
Any
very much,
questions?
Dr. Essaji. So, as we had mentioned earlier, for those who joined us after Dr. Essaji started the speech, please, you can use the chat box to ask your questions, or you raise your hand and then we can call you out to ask your questions. Meanwhile, let me just introduce a few of our colleagues who joined us. We have Peter Nyaga, who is our head of finance at Aga Khan Hospital, Mombasa. And we have Eric Ochieng, who is our head of hospitality and patients experience. Maybe if they have something to say as we wait for the question and answer.
Yes, good afternoon, ladies and gentlemen. My name is Peter Nyaga. I'm head of finance here at Aga Khan Hospital. And thank you, Dr. Essaji, for taking us through that discussion. Very useful to listen to your discussions, even after I've had them before. Because number one, I'm not a clinician, some of the things you will say will pass through the ears when you hear them once. But when you hear them repeated, they tend to stick. One thing I've found very useful dealing with Dr. Lalette closely as a colleague is her ability to break down knowledge, clinical knowledge, into what I found consumable by the layman. And if you have patients who require her services, I would recommend her because you'll be able to have a one-on-one talk that engages beyond just clinical treatment, but also considered your socioeconomic situations and other family factors that will enable you or your patients or your loved ones to improve the quality of life. And here at Aga Khan, we the service so that you are not going or having to go elsewhere outside Mombasa to seek services that would be best provided near your family members, and we'll be happy to facilitate any service that you require. So for KRA, of course, we have an account with you, and we will be eager to facilitate any treatment requirements that are needed, and even have more talks like this as and when required. So thank you very much for your participation. We appreciate the partnership we have. Thank you. Thank you, Janet.
Thank you, Peter. Eric, anything? Any comments? Okay, back to KRA team. Any questions you have, Harrison? Any clarifications maybe Dr. Essaji can address on behalf of KRA?
Hi, Janet. Sorry, I had minimized my screen, so I was struggling to unmute. Can you hear me?
Go ahead, Eric.
Yes.
Oh, okay, fantastic. No, I just wanted to say thank you to Dr. Essaji and the team for the great presentation. I think she's made it very clear that we need to build a lot of trust within our clients and our patients to know that these services are affordable and within reach. You don't have to travel so far. And if you have any inquiries, please feel free to reach out to us so we can give you clarification rather than actually traveling so far to get treatment that you can receive here. So once again, please feel free to reach out to us. I think, Janet, you can share our contacts and we can assist where possible.
Okay, thank you. Thank you, Eric. So, KRA, back to you. Harrison?
Yes, thank you so very much. Thank you, Dr. Essaji, for the wonderful presentation. Well, I would say it's been a wonderful experience, though during the presentation at times, there are some things you try to relate with and they're a bit scary, but then, you know, information is power. From our end, I would just want to say we are so very grateful. Janet, thank you so very much. I know this has been on short notice. We had a conversation like about, maybe like about 3 weeks ago, and we were able to discuss and put things together in terms of the kind of topics that we can engage. And I'm so glad. I just want to appreciate on behalf of my entire team that you've been able to mobilize some of the best clinical persons who are able to come on board and give us this kind of talk. We are happy. We appreciate. And by the way, it is through such forums that we get to appreciate the kind of services that are offered out there. So in fact, we are just getting to learn that indeed Aga Khan offers just so much in terms of this kind of specialized services. So I just want to thank you for making this happen. I know we have a long program. The partnership allows us to, enables us, affords us an opportunity to have a lot more. And I know probably in the next like 2 weeks, there's something else coming up. And we just feel indebted to you, Janet, and your team. Again, I would say thank you so very much. I want to believe that silence from my end and my people would mean that probably they're still digesting the kind of things they've just heard. It's so powerful. And I know over time, things may come up. And we are glad that graciously, from the last conversation we had in a similar forum, you opened it up for us that in case something comes up, we can always reach out to you so that you can make it possible for us to engage with persons who are able to attend to our queries. Otherwise, I'll just take this opportunity again to say thank you so very much for this kind of an engagement. We are looking forward to do more of this kind of forums, because they're actually going a long way to empower people, and not necessarily themselves in person, but we live around, we live with people, we relate with others, and information that we get in such kind of engagements will go a long way in helping other people whom we relate with. So it's really so powerful. It's really so powerful, and we just take it with grace and say thank you so very much. So from our end, Janet, thank you so much. Dr. Essaji, thank you. Your colleagues who created time to take part in this program, I just want to thank, with humility, I say thank you. And we're looking forward to engaging even a lot more. Otherwise, from our end, we say thank you so much. Janet, I would want to back to you. Thank you so much.
Okay, thank you very much, Harrison, and the entire KRA team. Thank you, Dr. Essaji, Peter, and Eric. I've posted our contacts on the chat box just in case you have any queries or clarifications you want to ask much later. This has been recorded. I'll forward it to you so that you can circulate to your staff who did not join. I know Christine sent her apologies. However, I promised her that I'll send the recording to her. So have a good evening, everybody, and thank you very much. Be blessed. Thank you.
Good evening. Thank you so much.